Today, as from the leaflet, we have the great pleasure to having Patrizia Burra, the head of the multi-visceral transplant unit of University of Padua. She's also the reference person of liver transplantation at ISL. So she's a very important person. I mean, I have the pleasure to know her since many years. Many years, but I mean, we're still running the show, which is good. And the title of her presentation is Liver Transplantation in 2022. Where do we stand? And most important, where do we go? So Patrizia, you have the podium. Thank you for being with us. You have the mic. Go ahead.
Thank you very much, Claudio. A great pleasure for me. I would like to thank Professor Tiriberi for this kind invitation. And it's really a pleasure, I have to say, to stay with you and try to discuss with you on what is really the position today, what you feel about the liver transplantation as anticipated by Professor Tiriberi. So let's start where do we stand? I think there are some old indications that have a different management. So it means that today we manage in a different way acute alcoholic hepatitis, NAFL, NASH, ACLF3, and transplant oncology. Then I will briefly touch on the concept of frailty and the more linked to the surgery, the use of machine perfusion, how we did change under the COVID-19 pandemic. So starting with the alcohol-related liver disease, it's unfortunately quite the bad news that we received from this study, where they demonstrated that during the pandemic, there was a significant increase in alcohol-related liver disease listing, plus 7%, and liver transplant, plus 10%. But what worries us is that the majority of the increase occurred in young adults and in patients with alcoholic hepatitis. And in fact, if we stay in alcoholic hepatitis, for the first time in the world, we had this experience published by Philippe Mathurin, who proposed the early liver transplantation to those patients, regardless the times of abstinence from alcohol before the transplantation for the first time. And actually, in a cohort of 26 patients, he demonstrated a 2-year survival of 72% in them, and only 24% in match controls. Since then, different centers in the world try to do the same. We decided, under the auspices of the Italian Association for the Study of the Liver, to evaluate those patients with an expected survival less than 6 months, in whom the liver decompensation became the priority compared to the pre-transplant length of sobriety. And we decided altogether that all those patients to be evaluated for the early liver transplantation absolutely needed to undergo a multidisciplinary evaluation performed by addiction specialists, psychiatrists, psychologists, and social workers, together with the transplant hepatologists, surgeons, and intensivists. And that led to this publication very recently. The pilot study was coordinated by Giacomo Germani from our center, and 4 liver transplant centers accepted to be part of this new study. And actually, there were 93 patients with acute alcoholic hepatitis referred to our centers. And as you can see, the selection criteria are very strict, and in fact, only 16 patients at the end could be transplanted. But the results in terms of survival are very easily to be read. In fact, you see 100% at 3-year survival of patients transplanted, 65% for patients responding to medical therapy, therefore not transplanted, and only 35% in patients not responding to medical therapy and not suitable for liver transplantation. If we look at what worries us, the recurrence of alcohol consumption after transplant in our study was quite good. Only 2 out of the 16 patients, meaning 12.5%, which is a little bit optimistic compared to some other publications. This is the study from, again, the group of Philippe Mathurin, Alexander Lovett. They published at the same time that we published the paper. However, their experience with the early liver transplantation is less positive, let's say, with 1/3 of the patient who experienced the alcohol relapse after the transplant. It could be that despite the selection criteria very similar, the management of the patient maybe after transplantation might differ. This is an interesting, a very nice paper that was recently published where they describe what is today the best way to manage those patients with a patient-centered integrative care model for alcohol use disorders. I believe that that should be applied either before transplantation and after transplantation, involving the family, involving the social support, and also, if needed, the social worker. Interesting enough, this is a recent study that said that, however, despite as I said, the majority of the patients with deny for several reasons, mainly psychological reasons, liver transplantation, 1/3 of them can recover from acute alcoholic hepatitis, and the favoring factors are younger age, not so much prolonged INR, and a lower peak of MELD. However, at the end, if you check and you compare the recovery with the transplanted patient, still the survival is significantly higher in patients undergoing liver transplantation. The other point is that if we do experience recurrence of the disease of cirrhosis due to alcohol intake after transplant, there is not very common to see retransplantation over to those patients. This is a registry from the United States, 20 years of evaluation. As you can see, only 74 retransplantation on the country, representing 1% of all retransplants, and that despite the survival comparing alcohol versus non-alcohol related liver disease was absolutely identical. So that means that a retransplantation is not commonly offered to those patients. What about NAFLD and NASH? This is a recent report by Soba Younousi on the global prevalence of NAFLD. We are up to 30% all around in the world as a median. And we know that in the setting of the liver transplantation, actually in this US registry from the female population, as you can see on the right side of the slide, it was really the leading cause of liver transplantation in the country. If you look at some other experience, this is our center experience, it's a little bit different. In Europe, we have an average of 10% as an indication, so much lower than the United States. But still, the trend over time really increased. In this study, Alberto Ferrarese evaluated our waiting list registration between 2006 to 2020. As you can see, increasing from 2.5 to 23%. And that was true for either decompensated cirrhosis, 1.8 to 80%, and hepatocellular carcinoma from 4 to 30%. So the changing in the scenario of NAFLD and NASH liver transplant is seen all over in Europe too. Why do we worry so much about the management of those patients? Because if you look at the different prevalence of individual comorbidities in those patients by year of transplantation, you see the most recent years, there is association with diabetes, cardiovascular disease, with the renal disease, and some other diseases. And in fact, diabetes is most common comorbidity in those patients, is associated with impairment in the peri-transplant time, including the longer hospital stay, including the higher peri-transplant mortality, a lower discharge at home, and also an higher 30-day readmission rate after discharge. But we also know that following those patients after transplantation, the prevalence of diabetes ranges between 30 to 40%. And we also can experience the new onset diabetes between 13 to 28% in the first 3 years after surgery, with a higher association with infection, with cardiovascular events, therefore reducing the overall survival. And in fact, in this study, they confirm that patients with diabetes have a significantly lower long-term survival comparing to patients without the diabetes. And after controlling for age, BMI, HCV, and MELD, diabetes remain a significant predictor of that. The other point I wanted to make is related to the cardiovascular events. In this case, and in the NAFLD patient, we have really to look at the cardiac function. This is a study where all patients, 228, underwent a coronary angiography as part of the liver transplant evaluation. And they found in the NASH population that more than 50% of them presented with any level, with any kind of CAD. That's why, because sometimes the coronary angiography is deferred in patients with decompensated cirrhosis. The cardiologists, they believe that they perceive that there is an increased risk of complications due to the invasive nature of the procedure, in particular bleeding. However, if you try to combine the different levels of evaluation, what we did in our center, you can really create a cardio workup algorithm. And actually, I would say that all our patients will undergo the second level, at least, of evaluation. And when the dobutamine stress test is even mildly abnormal, we do go ahead with either the coronary CT or with the coronary angiography. Then we decide about the selection of patients together with the cardiologist and with the intensivist. The problem is still remaining, the high rate of events, cardiovascular events after transplant, reported to be up to 40% at 5 years, compared to only, let's say, only 5 to 10% in non-NASH recipients. And as you can see from the list, you can have also some fatal events such as the sudden cardiac arrest. The other point that I wanted to make is that the increasing registration, this is again from the United States data, increasing registration for NASH mirrors diabetes, as we already said, but also obesity. And in fact, this is another point that we are observing weight gain progressively after transplantation in 1/3 at 1 year, in 40% at 5 years, associated with the age and associated with the pre-transplant obesity. And the problem is that among the obesity, we can have the severe obesity and the morbid obesity, which are 4 and 5 in this slide, meaning that from all the studies, pathological obesity was associated with a much lower survival after transplant. And today we are still discussing when we have to treat those patients with the morbid obesity in particular, with the bariatric surgery, if we should be done before transplantation, during transplantation, after transplantation. This is a review paper where you can see the list of complications, major complications, and mortality, considering the 3 different options. Some center with a lot of experience, such as the Mayo Clinic in Rochester with Julie Heimbach, they go ahead much more with the simultaneous bariatric surgery, the sleeve gastrectomy mainly, and liver transplantation. And as alluded to in my summary slide, there is also the chronic kidney disease associated with NASH. And that's a pre-transplant chronic kidney disease is associated with a post-transplant mortality. And this is in addition to the effect that the drug, the immunosuppression, will cause a chronic kidney disease in 1/3 of the patient anyway, regardless the etiology of liver disease. In fact, this recent study confirmed that if you compare 1 year after transplantation, the GFR in patients transplanted for NASH or non-NASH, you see there is a difference in terms of declining GFR after liver transplantation. As I said, there are old disease, old onset of the disease, but the new in terms of proposing liver transplantation, which is acute on chronic liver failure. In particular, for the most severe CLF3, for several years, transplantation was a contraindication. And so that started to be considered, let's say, nearly 7-8 years ago. This is one of the first studies from Arthur, from the Lille group, then he moved to London. And they show that if you perform a good selection of patients, a CLF3 can be transplanted with 84% survival at 1 year, comparing to less than 8% survival if patients were not transplanted. However, even today, what we do know is that we do not have really a proper estimation of the severity of the disease and transplantation. And the score that is commonly used, the MEL sodium, to to estimate the 90 days mortality, it doesn't work properly in this kind of patient. Let's see, look at the category of male between 20 to 29. If you have a expected 90-day mortality of nearly between 19 and 20%, you then have the observed mortality in the dark blue column of a CLF3 patient, which is 64-65%. So absolutely no comparison. And this is why a group of intensivists coordinated by Thierry Asner from Strasbourg, he proposed to use some variables such as the lactate, the mechanical ventilations, together with the age of leukocyte counts, to create the TAM score, which goes from 0 to 2 and greater than 2. And actually, it nicely stratified the risk of patients with 100% survival with TAM score 0 and less than 10% survival at 12 months with the TAM score greater than 2. However, despite the score is very useful, there are some other complications of liver disease not included in the score that can affect the survival. This is a paper from Vinay Sundaram that unfortunately passed away recently. And he demonstrated from the US database that the portal vein thrombosis at the time of transplantation was associated with a lower post-transplant survival in a CLF3 patient. What about frailty that I mentioned? I think that today, despite we all know that the patient with cirrhosis for the malnutrition, encephalopathy, they are frail. We have been studying sarcopenia a little bit more in the most recent years, but let's say that overall, we believe that frailty should be definitely considered one of many criteria when evaluating transplant candidacy and suitability to liver transplantation. This is what Jennifer and I with the group developed quite nicely about the global assessment of transplant candidacy, not including only dysfunction, cardiac function, renal dysfunction, but also muscle wasting, also undernutrition, also physical inactivity. And the index that I really prefer, since it's really very easy to be used, is the liver frailty index. It is composed of 3 components: the grip strength, the chair stance, and the balance testing. When you insert in the calculator the results, you can obtain 3 scores, and the 3 scores correspond to robust, pre-frail, and frail. This is very important since quite a recent